Thank you for inviting me to talk about my favorite topic. I just have to say that I don't have any conflict of interest to declare. So, as you may have read, Kate Sims from the team in Australia had estimated that in the absence of further intervention, there would be about 44 million women having cervical cancer in the next 50 years and an estimated 25 million deaths. And the majority of these cases would arise from low and middle income countries. With the recent approval of the strategy for the elimination from WHO, the section that is devoted to screening is based on the idea that if we are able to reach 70% coverage of screening, we would be able to avert about 12 to 13 million cases in the next 50 years. To do that, the strategy is based on an HPV-based screening twice per lifetime and a coverage of 70%. And obviously, that in order that this to be effective in averting these cases, we need to manage all the screening positives. So what is the screening situation? If I take the work that was presented at IPV by our colleagues Bea Serrano and Laia Bruni, we see that HPV testing is not very common yet in low and middle income countries. The majority of countries are recommending VIA, and some groups, some countries are having more than one primary screening test as a recommendation in their national programs. And if we go to this to evaluate the coverage based on a complex approach that the ICO group have done in the last 2 years, trying to retrieve from web bases, from publications, from reports in the countries, what we are seeing is that ever screening in a lifetime in the world is estimated to be about 38%, but as you have seen in other attempts to estimate that from the STEP studies or other approaches, 88% of high-income countries would have ever a screening test. And I'm not talking about efficient screening test, it's just ever screening. But look at the low and middle income countries, the rates are extremely low. And if we go to Pacific Islands, we go to an 8% ever screening test in a lifetime. So we all are aware that we have a very big task ahead of us. So we need to plan, and we need to really think carefully how we can manage to implement new programs. And for me, I have set up like 4 windows. No? One is to, in order that we can reach a large number of women, we have to think about what is the population that we are prioritizing as a target groups. And for this, I think we have to consider the age, the screening history of the women, and with this I mean never screen women, and what is the HIV status in our population. As well, we have to discuss and argue with the professionals and with the women themselves as well, whether approaches using self-sampling versus a speculum exam to everybody is going to work, and what is our selection of these 2 options. What is the triage and treat approaches, and finally, how are we planning our treatment approaches, knowing that we have now ablative interventions that can work pretty well in the majority of the cases. So I would say that it's coming very evident that we need, when we want to start massively in a country or in a region, we need to restrict 30 to 49 years as the best target ages. We need to prioritize the never screen, and we will have to stratify by HIV status when this is an important aspect of comorbidity in our population. Clearly, data is very strong, arguing in favor to self-sampling, and which allows us to use an HPV test. More complex is the situation of triage, and I will go over, but I think the next coming possibilities is to use a visualization of the cervix with applying, maybe if it's feasible and we can really prove that this works, artificial intelligence applied to the reading of the images, and maybe using HPV type restriction. Very important is that we have to ensure treatment capacity, and thermal ablation seems to be the first line approach, but we have to guarantee that professionals are ready to do that, and when women cannot go through an ablative approach, that there is a second option like LEDs or lip conizations, which in many cases I have seen personally that when you look at what the number of professionals available to do that are very limited in primary health care level. So the scenarios we have for triage, I think we are all aware that many countries are using VIA, but what we are seeing more and more when we analyze the data is that there is a poor reproducibility and low accuracy in many settings, not in all settings, but in many of them. You cannot predict what VIA is going to give. And what it really is the issue is that I think one of the major problems is that you get an under-treatment of women. Some countries are using or proposing visual evaluation for treatment, the VAT, which really it happens that, that it over-treats, and we have to understand what does it mean over-treatment in a large number, and I will show you some information. And this is done, for example, in El Salvador, has been proposed in Papua New Guinea, so that any woman that is HPV positive goes into treatment after making sure that this woman did not have a very big lesion or an invasive tumor. There is as well a lot going on around in using visual in imaging. There's many portable colposcopes now, and cell phones are being used, and obviously the image one gets is better than the naked eye from visualization, but still I have not been able to find data that shows a clear benefit of just having a better image at the screening room in improving the outcome of the screening or the triage approach. We are working now on the visualization using VIA plus an automatic reading with using artificial intelligence, what we call ABE approach. The excellent results, preliminary data from Guanacaste. I'll show you some slides. And there is a lot of information now coming because several tests are producing a full genotype approach in their platforms and providing information on the high risk HPV types, and probably HPV genotype restriction may be an important added value. And there's some work, and Lynn has been as well working on that, that may be useful to use as a triage approach. Some work is going on as well in testing for several aspects of the carcinogenic process, not only the HPV viral type, viral load, and methylation, but as well cellular markers. And that the work of Andreas Kaufmann in Ethiopia is going on, and he's trying to show whether this could work in a low resource settings. So just let me show you the work of Toliman et al. This is a group from working in Papua New Guinea, led by the Australian group, where I think Susan is as well a co-author of that. And what they explore is the different screening and triage approaches using visual inspection of after an HPV positive test, or using self-sampling and treat the women that were HPV positive, or using a clinical collecting sample and treat these women that were HPV positive, or collecting an HPV positive and using VIA as a triage. So here the two tables, I just show you the rough numbers. And when we triage for visual inspection, what we see is that out of the women that they are HPV positive, VIA positive, with VIA, we would be treating all these women, but we will miss about 18 women that they had cytology result of high SIL, and this cytology was of very high quality. Well, when they use treating all the women that were HPV positive, as you can see, they will treat many more women, because there are 64 women that they are not positive, but that they will treat almost everybody with a high SIL. And this is the scenarios that we have to handle when we are proposing a screening test and a triage. And that's what I think is what we have to reflect. Are we able to miss half or more than half of the women that have a lesion if these women can only access screening and triage once in the lifetime? Or we are able to accept, because we have enough resources to treat women, to over-treat a certain proportion of women. So that's a discussion point. Let me just summarize the work that has been done in Guanacaste, and you know the study on the natural history, and the group of NCI led by Mark Shipman used the cervicograms that were taken in a baseline in all the women, and they follow them up for over 7-8 years, and so I think even they reach 18 years follow-up using the registry. So what they managed is that they took the picture, and they thousands of pictures were evaluated and compared to the histological outcome, what we call the ground truth. And an algorithm was generated that evaluated the risk or the probability to have a CIN2 plus between 0 to 1. And this result was evaluated using ROC and AUC statistics, and the data was compared to the performance of HPV test, of cytology, and colposcopic impression. All this has been published, and maybe you are familiar, just for those that they have not seen the results, just to show you that it was an amazing result, that it was even better than the HPV predictive value. The area under the curve was almost complete. And when they used the same algorithm in the triage, the information was a bit, or the estimate was a bit lower at 0.87%, sorry. But the difference between the two is that if you use speculum imaging in all the women in the screening approach, you will have to run all the gynecological exam to all women. While it may be adequate to lose a bit some of the accuracy, knowing that under the triage, you will have to triage only and to do a speculum visit only among those that they are HPV positive. So that's another important difference between the two. Very recently, Maria De Marco has published a large data set from Kaiser Permanente, data that has been used to update the guidelines in the US. And what is, I think, very interesting is the confirmation that there is obviously a different risk of progression to high-grade lesions CIM3+, based on the differences according to the genotypes. And what is really, I think, interesting is that the threshold value for US is 5%, above 5% probability to predict a high-grade lesion is accepted to be amenable to treatment, while less than 5% should wait and see. And so these types 39, 51, 56, 59, 68 in the US population with large numbers represent almost a quarter of all the screen positive. So the idea is that maybe there are some types that should be managed when you have only few opportunities to screen women, and you should make sure, or one should make sure that these women are not being lost in managing. But there are a substantial group that may require much less aggressive approach and could probably even be sent to a next round when we have very limited resources. So for treatment, I think what is important is to try to see whether screen and treat approaches work, because that's the best way to diminish the loss to follow up. Thermal ablation is easy to manage in primary health care and has been shown to really solve many of the structural issues of cryotherapy. And still about 15% of the women, depending on the series, may not be amenable to be treated with an ablative approach, so because of a large lesion or a T-zone that it's not visible. So we'll have to manage this 15% of women that may not be amenable to be treated on the spot. Also, I think there is a very clear evidence that at least about 20% of the women may not accept an immediate treatment, may want to think about what's happening to them, may have to consult in the family what to do. And so we have to be aware that not everybody will accept an immediate surgery or ablative approach. As well, and I've seen this personally, sometimes personnel is not available. So one is the screening process and some of the first encounter with a woman, but the devices sometimes are not ready. So there is an issue in the screen and treat, and it's common to have some failure, and we have to account for that. And then there are technical issues like how trained we are to distinguish for the suitability of ablative approaches, and we need to have a very good reference system. So when we implement it, we have to think as well, how are we going to go? We don't like pilot studies because sometimes they stay there for very long, but demonstration projects are necessary to really make sure that we train the people, that we train the whole process. Many of the countries will not be able to start at the national level, and they will have to go either at the district level, and how long can we manage these different approaches in the screening in a given country. One of the issues that I think it's important and sometimes is not being raised with enough strength is that for me it's important to plan screening taking into account what is the availability of the capacity of managing invasive cervical cancer cases that I detect when I screen women. If I screen a certain population, even if it's with an age restriction, I have to make sure that I cannot say to this woman, oh, I'm sorry, you have an invasive cancer and I don't have anything to manage you. So how many can I manage in my settings? and probably start the planning from the last moment of how many can I manage, not only invasive, but as well precancerous lesions, and then go back. So if I can manage in a given region X percentage of cases per week or per day, then I can call the women that would generate these cases. In many instances, I've seen that screening starts and then treatment is, oh, I have to treat these women, and there is not enough planning. No? As well, I reiterate, it's important to understand what is the treatment capacity. We know that ablative approaches are easy, they're not expensive, they can be really managed and can solve many of the small lesions and really generate a big impact in our population, but we do need people to be trained. So obviously we need to work on data collection. Ideally, we would love to have cancer resistance all over. There are minimal data collection that can be done, and I think unless we collect minimal information, we will not understand what is the impact and where are the errors or mistakes or bottlenecks of our process. And it's very important. There are now low-cost approaches to data monitoring, like cell phone software, for example. Bill Gates with Global Health Labs is working on a phone software. As well, DHS2 has been working on approaches to traceability that are not really difficult and can be handled on a cell phone. So I think this is an important issue to consider. I would think that one scenario that I think it could work very well is to start with a self-sampling. We use an HPV test if we can divide the HPV oncogenic risk into two groups, high risk, low high risk types, we could have a group of women that immediately after we assess them gynecologically, those that they are positive, we can, if we have available an ABE test for just to make sure that there is a high probability that this woman has a high risk lesion, a precancerous lesion, and then treat these women. In the women that they are tested with a low high risk type, we could just have a visual inspection, have an ABE test if possible, and just make sure we are not missing any major cancer. If there is a lesion, we send this woman for treatment. If not, we can send this woman for the next round, and we would save about 25% of our population, probably. That's just a scenario that could make things more agile and restricting the number of women that need to be treated. We have, before embarking on programs, there are several tools. I think Natalie yesterday showed several. PATH has been working on a new tool that helps programming and thinking about what is the scenarios that we are going to have with using different screening and triage approaches. There is the C4P tool, WHO, that it really evaluates the cost effectiveness of approaches and requires an assessment of an economist in situ. But this tool is easy to manage, it's free access. I just put here the web page, and I hope you can play around with it. And there is a video that shows the outputs, very simple outputs, and really shows compares the visual inspection with HPV, and then adding a proper triage, either with visual inspection or with an enhanced triage with ABE, and how well are we performing. As well, it gives you information about treatment and cost and saving when you use self-sampling. So in summary, I think the impact of screening programs may be limited by availability of treatment facilities, so we should consider that. Self-sampling and HPV testing are key elements for reaching high coverage and high accuracy. And selection of triage strategies remains unsettled in low-resource settings, but new low-cost approaches are likely to increase accuracy and affordability. We need to think carefully on data monitoring because this is critical to evaluate what we are doing. And while under COVID, I think cervical screening should be undertaken within a safe environment. If we are not able to provide a safe environment, we better delay our intervention 1 or 2 years. But there are centers I've seen, I heard yesterday the work in Zambia that they have managed really to produce a very interesting safe measures. I've seen in Botswana as well extremely good approaches to keep on doing screening within COVID, and I guess that Lynn has data on that and how she can as well keep on moving screening even with COVID. And I want to thank all the teams at PATH and at NCI that have helped me to bring this summary here. Thank you very much.